Afternoon. Is everybody here or anyone else to join?
Good afternoon, Nishant. I think Niroshan is yet to join.
All right, okay. Shall we wait for a while or I think probably we can start because of the time concerns. And,
Yeah, sure, no problem.
and I'm sure he will join later. So, very good afternoon to all of you. And so today we are going to do the eighth episode of Uromet, Urology Monthly Education for Trainees. And today we have the all-important topic, urolithiasis, and we have four uh, senior registrars or residents and trainees to uh, discuss the subtopics. And we have two experts panel with us today, Dr. Ranga Wickramarachchi, consultant urological surgeon from Faculty of Medicine, Patalavala Defense University, and Dr. Niroshan Seneviratne, consultant urological surgeon from Sri Jawadanapura General Hospital. So there is a slight change of the topics today. So the first speaker will be starting about the pathophysiology and metabolic stones. And as per the request, Dr. Tivika will be presenting after the first speaker on obstructed system and stones in pregnancy. So without further ado, we'll start with the first speaker. I'm sorry I couldn't introduce my co-moderator, Dr. Munipriya Villarachi from Polonnaruwa General Hospital, consultant urological surgeon. So I would invite Dr. Neranga Samarasinghe to deliver the first presentation, that is pathophysiology of stones and metabolic stones. Over to you, Neranga.
So first topic is the pathophysiology of stones and metabolic stones. I'm Dr. Samarasinghe from NHSL. So this urinary stone disease has plagued human race since the earliest beginning of the civilization. These urinary calculi are the third most common application of the urinary tract, exceeded mainly by this urinary tract infection and pathological condition of the prostate. Because this stone recurrent rate can be as high as 50% within lifetime, and the incidence depend on the geographical, climatic, ethnic, and dietary and many genetic factors for variations. When it comes to pathophysiology, there are multiple theories to explain the urinary stone disease, and they are a bit of incomplete, and there are no further conclusions. The major expected one is the supersaturated urine. So urine saturation will depend on the urinary pH, the ionic strength, the solute concentration, and the complexation. The urinary pH varies during the day and night and depend on dietary factors and depend on metabolic condition as well. Ionic strength depend on the relative concentration of monovalent ions in the solute, mainly in the urine. Then the concentration, the greater the concentration of two ions, the more likely they are to precipitate. So it reaches specific point term, the solubility product, the solubility coefficient. The concentration above this point are capable of initiating the crystal formation and permeation of this heterogeneous nucleation and homogeneous nucleation. The word complexation means there are availability of specific ions in the solution. Other substances found in the urinary tract, including magnesium, citrate, pyrophosphate, and variety of other trace metals, which may affect as inhibitors of this process or promoters of this process. There's the two theories. One is the nucleation theory. Urinary stones originally start from crystals of foreign bodies, which are immersed in supersaturated urine. But for this theory, there's a drawback because not always form in patients who are hyperexcretors and who are at risk for dehydration. Also, one-third of stone formers, if you analyze their 24-hour urine collection, they are seem to be completely normal. Then there's another theory, the crystal inhibitor theory. They are the calculi formed due to absence of or low concentration of natural stone inhibitors. including magnesium, citrate, pyrophosphate, and variety of trace metals. The drawback for this theory is there are many people who are lacking such inhibitors, but they may never form such stones. And others, even with abundance of inhibitors in there, paradoxically, they don't have the stone formation. So when it comes to the composition of stone, there are two main components. One is the crystal component, other one is the matrix component. The crystal component is the multiple steps are involved in the crystal formation, including initial nucleation, growth, and aggregation. This nucleation is induced by a variety of substances. There can be proteinous substance, crystals, foreign bodies, and other particular tissues. And the theory of mass precipitation or intranephric calculosis suggests that when these solids goes to this nephron, distal tubules or collecting tubules of both can become plugged by the crystals, and this will depend on the time of permeation as well, thereby establishing an environment of stasis which ripe for further stone growth. And the anatomical ranges in this PUG obstruction will further slow this process and further aggregate the crystal formation. Then the matrix component composed predominantly of the protein with small amount of hexose and hexosamines, and there's a separate subcategory as a matrix calculus. This can be associated with previous kidney surgery or recurrent urinary tract infection, and it has a gelatinous texture. Usually, they are radiolucent. In clinical practice, they can be confused with other filling defects in CTIVU and in CCT, including blood clots, upper tract tumors, and fungal bezoars. So when it comes to the stone types and their related condition, when it comes to calcium stones, 80% of the stones are calcium stones. So this calcification can be within the collecting system or within the parenchyma. The term nephrolithiasis is the calcification can occur and accumulation in the collecting system. When the term comes to nephrocalcinosis, is the calcification in the parenchyma of the kidney. So this condition can be associated with increased bone absorption, increased bone resorption, increased absorption from the gut, and depend on the defects of renal filtration, like renal tubular acidosis, increased uric acid level, increased oxalate level, and reduction in the citrate level. When the term the struvite stones, this is mainly composed of magnesium, ammonium, and phosphate as renal staghorn configured calculi. These infection stones are associated with urease splitting organism, including Proteus mirabilis is the most common one. Other ones are the Pseudomonas, Klebsiella, and Staphylococcus, and even Mycoplasma species. So this formation need alkaline urinary pH, which is done by this urease splitting organism. Then we have uric acid stones with the condition like gout and myeloproliferative disease and rapid weight loss. And even those who are treated for malignant condition is cytotoxic drug, who are getting this uric acid phenomena, a urinary pH, they need a consistently less than 5.5. It means they need an acidic environment for this uric acid stones. Then the cystine stones, this classic cystinuria is the inherited autosomal recessive condition which gives rise to cystine stone. And there are xanthine stone, the rare ones, the congenital deficiency of xanthine dehydrogenase enzyme. And there can be drug-induced stone as well. Common example is the Indinavir. It's a treatment used in HIV and immune deficiency treatment. And this is the stone which is radiolucent even in the non-contrast CT. Then we can consider other classification of the stone by etiology. As we mentioned previously, there are stone can be associated with non-infection stone, infective processes, and depend on genetic causes and the drug induced. The non-infective stones are mainly calcium stone, calcium oxalate, calcium phosphate, and uric acid. Infective stones, most of the time, they are associated with magnesium phosphate and highly carbonate apatite and ammonium urate. Cystine and xanthine are the genetically induced stone, and this indinavir is a drug-induced stone. Further, we can classify them depending on the stone size, whether less than 5 millimeter, 5 to 10, 10 to 12, or more than 20 millimeter. And we can classify them depending on the stone location as well, depending on the calyceal, renal, ureteric, and urinary bladder location. And main one is this X-ray characteristic of a stone. So we can categorize them clearly radio-opaque or radiolucent, and there's a poor radio-opacity category as well. This calcium containing calcium oxalate monohydrate, rehydrate, and calcium phosphates are radio-opaque one. The radiolucent ones will be uric acid, xanthine, and drug-induced one. This magnesium containing one and cysteine one has a poor radioopacity. And there are many factors associated with this stone formation. There can be general factors, disease-associated factors, genetical factors, and anatomical anomalies as I described previously. So general factors will be for the high risk of stone formation will be early onset of urotheliasis. When it comes to children and teenagers who are coming with early onset stone formation, they are having high risk of recurrent stone formation. If there's a family history and recurrent stone formation, and if there's a short time since last stone episode and infective stones, they tend to recur. And CKD is a well-known risk factor for stone formation. Then disease associated is the metabolic condition like hyperthyroidism, metabolic syndrome, these mineral-borne disorders, and polycystic kidney. And gastrointestinal diseases, especially when there are gastrointestinal bypass and weight reduction surgery, are associated with stone formation. And genetical condition can be the cystinuria, oxaluria, and renal tubular acidosis type 1, which is the proximal one, and xanthinuria, and Lesch-Nyhan syndrome-like condition. And the anatomical abnormalities, because they will promote the stasis and medullary sponge kidney and PUG obstruction. And there's a calyceal diverticulum or urethral stricture and VUR, and if there's a horseshoe kidney-like conditions. When it comes to metabolic stone evaluation and further management, according to EAU 2022 guideline, all these stone analysis should be performed in all first-time stone formers. And the indication for repeat stone analysis is needed in the cases like recurrence when occurs under pharmacological prevention, and if there's early recurrence after interventional therapy with complete stone clearance, or if there's a late recurrence after prolonged stone-free period. When it's come to this calcium oxalate stones, we have to assess the urine in this patient. We can categorize them whether they are hypocalciuric, whether hypoxaluric, hyperuricosuric, or hypomagnesuria, and hypocitraturia. So the basic investigation will be serum calcium level and parathyroid hormone level if you are suspecting this hyperthyroidism condition. And we should assess their urinary pH level and 24-hour urine assessment. If the urinary pH is more than 6.2 in a 24 urine collection, that may indicate more towards renal tubular acidosis. And there will be condition associated with hypoxaluria, hypomagnesuria, and gout. In management wise, we can use this thiazide or alkaline citrate in hypercalciuric condition, and alkaline citrate or sodium bicarbonate in case of this hypocytraluria condition, and pyridoxine as a treatment of hypoxaluria conditions. When it comes to calcium phosphate stones, the most commonly it can be associated with hyperthyroidism and renal tubular acidosis. In this if they associated with hypercalciuria, we have to treat with HCHT or bicarbonate or alkaline citrate therapy. When it comes to uric acid and ammonium urate stones, the causes can be dietary excess, endogenous overproduction because of the enzyme defects, or associated with myeloproliferative disorders, chemotherapy drugs, or gout. So alkaline citrate to alkaline is the urine, and allopurinol in hyperuric urine. We can use allopurinol in patient when this hyperuric urate stone forms, and there are these struite and infective stones. So these stones mainly depend on the recurrent infection. So we have to remove the stone material as completely as possible. So prescription of antibiotic in case of persistent bacteriuria and urine acidification, we can use this ammonium chloride or methionine as the recommended treatment. When it comes to cystine stone, we have to maintain a urine pH more than 7.5 because it will improve the cystine solubility. The thiopronine is currently the best choice for cystine reduction. Thank you, sir.
Okay, thank you, Niranga. So I think our two experts are here. So Niranga, you can stop screen sharing. Can you stop? Yeah. So I'll hand it over to the expert panel, Dr. Ranga Vikramarachchi and Dr. Niroshan Seneviratne, to clarify a few things from you, few additions. Anything, Dr. Ranga?
Yeah, Niranga, what do you know about the stone analysis?
Yes,
analysis of the
stone analysis, there are chemical method, And there is this radiological method with infrared spectrometry.
Mhm.
The chemical method, and there are Sri Lankan researchers as well. It is more cost consuming, and currently the chemical analysis is not so recommended. The gold standard is this X-ray spectrometry with infrared usage.
Any
For that, we
evidence?
should combine that result with for that, sir, we should combine our result with this urine spot sample with pH analysis and 24-hour urine samples to get a proper idea of the metabolic evaluations.
Any idea about, now you mentioned about steroid stones and the infection stones, and Sri Lankan Staghorn calculi, is it the same as this or any difference? Any evidence
Yes,
from
sir.
Sri Lanka?
No, there's a difference, sir, because yes, sir. In Europe, they mention this Staghorn calculi, the steroid stone, but there are research done by Anuruddha sir, and in Sri Lanka, they found that the PCNL specimen they analyzed, sir, they were mainly calcium stone in Sri Lankan context, sir.
Do you think will it affect or interfere with our management strategies, or will be the same as in the West?
Yes, sir. This calcium stone, they are more density and they are very difficult for our treatments, sir. So this steroid, if we treat the infection properly, they are, because they are associated with infection. So for in Sri Lankan context, for this Staghorn calculi, they warrant a treatment modality, sir. Either open or PCNL methods, depend on the available techniques.
If you don't treat the Staghorn calculus, what are the issues? Can you just leave it with conservative management? Because the Staghorn calculi, usually they don't cause any significant obstruction as such, most of the time. So if it is non-obstructing a Staghorn calculus, can we leave it?
Yes, sir. There was a conversation on that issue, sir, because with the availability of low resources, whether we can leave non-obstructive Staghorn calculi as in Sri Lankan context as calcium and it's not associated with infection. There's a possibility of going for conservative management as well, sir. But we should have the proper surveillance for that patient.
And but what is the traditional teaching from the West?
West, as they are associated infection, they all should be treated, sir.
What they say is if you leave a Staghorn calculus, then the chance of the deteriorating the function of that particular kidney is higher, but which may not be directly applicable to Sri Lankan context. We don't know. We need a better evaluation.
Yeah, I think that's very productive. Just wanted to add one or two things. I think as Dr. Ranga mentioned, the context of infective stones, because in the West, most of the Staghorn stones are steroid stones, and there are a lot of infection associated. The other important thing in the management is high rates of infective complications in that sort of Staghorns, as well as in the West, if you have a Staghorn, you're supposed to have a DTPA study, because most of the time the infective stones are associated with non-functioning kidneys, whereas in our people, we see most of the oxalate stones, the renal functions are much preserved, probably because less amount of pyonephrosis and all. And to add, I think the classic teaching of non-operative or conservative management of Staghorn calculi causing loss of renal function is coming from the historical paper of Blandy and Singh.
Yeah.
Is in 1970s. So they have described this the very high amount of mortality and morbidity associated with non-treated, even asymptomatic non-treated Staghorn stones. But then I think recently the literature has changed. Nowadays, there are many papers coming where you can treat selective group of Staghorn patients, probably with conservative management and some sort of prophylactic antibiotics. I think correct, Ranga. And then we'll hand it over to Dr. Niroshan Seneviratne. Dr. Niroshan, are you there?
Yes, Ranga. Few things. I think Ranga covered most of it. Few things in terms of patients with stone disease in CKD. Those patients, what is your general idea when you treat when you have to treat those patients with medically? What are your cautions? What you described already.
Yes, sir. CKD patient, there's association of stone formation, which is proven, sir, which act itself as a risk factor. So we have to assess their current renal function and level of deterioration in the initial ultrasound scan if there's any obstruction causing hydronephrosis or hydroureter. And we have to assess the contractile kidney function as well, sir. Whether this obstructed kidney, the non-functioning, the really high functioning kidney or good kidney, whether it's obstructed. And depend on that, if there's a single functioning kidney, it's become an emergency, sir.
Yeah, the most of the patients with renal impairment, because they are sometimes recurrent stone makers and they are on long-term medication, especially uric acid and mixed stones. So they are put on long-term potassium citrate. And people forget that these patients can end up in dangerous hyperkalemia. So you need to be cautious in these patients when you prescribe long-term medical treatment, ignoring those factors. And also there are, as Nishanta said, even with patients with staghorns, their renal deterioration is far more superior. So if you have patients with staghorns with CKD stage 2 or more, those patients have to be given priority, even they are asymptomatic, to get rid of these stones for long-term renal preservation. So those practical tips you should be knowing. And in terms of practicality, though you say renal stone analysis, how practical in your respective units you do renal, the stone analysis?
At the moment, sir, we are doing it as a research level only, sir, not on in the routine basis, sir. And we are focusing for this recurrent stone formers, sir, and who are having bilateral stones and with recurrent presentations, sir, we are promoting. Otherwise, we are not practice routinely, sir.
Yeah, so I think it's a good practice as in the West to do the stone analysis and then try to find a metabolic cause with those factors rather than doing the full range of tests to find whether there is underlying cause. Secondly, that these patients may not be having underlying metabolic cause but related to stone, but you will find other metabolic diseases which then coexist. And if you control them, for instance, diabetes and obesity, those factors, if you control, their recurrent stone formation will go down. So it's from the patient's perspective, it's important to do a stone analysis so that they are aware that these conditions, otherwise unduly, they will go to certain dietary restrictions and so on.
And very good. But to add to what Niroshan said, Neranga, any idea about now, say, patient with end-stage kidneys full of stones awaiting KT? How will your management would differ from any other patient?
If the patient is awaiting kidney transplant, sir, and if the stone, if the kidney is obstructed with stone and there's a cross-site necrosis, the patient might be benefit from offering a nephrectomy, because in the context of next renal transplant, it might give the relevant space for the transplant surgeon to do a proper transplant there, sir.
Niroshan, anything else you want to say about this scenario?
Yeah, it's a tricky situation. It all depends on how much stone burden is there, and also because anyway the metabolic situation is deranged on those patients, and they are going to form stones. But when the new kidney comes in, probably the condition will be resolved. So unless you're threatened with episodes of infection, there is no real indication to make the patient stone free prior to transplantation. But as you quite correctly said, in one of the pathophysiology is to find out any obstructive cause. So these are the things, if you are planning a patient to um, um, for kidney transplant, these things have to be rectified earlier, and those patients need pre-transplant nephrectomy prior to going ahead with the transplant.
Nishant,
Yeah.
I think we are good to move with the.
Yeah, I think we'll move it to the next one. Few things to read for the benefit of the exam purpose. I would like to suggest you to read the theories of the stone formation. I think Naranga mentioned some of these, but you need to know the supersaturation theory. You need to know some of the terminologies like epitaxis as well as metastable state, and what is solvent product and what is formation constant. Those are the things to read for your exam purpose, and also something about the vascular theory of stone formation and those new theories. Right. So then we'll move to the next speaker. As I said, we will be having a little bit of a change in the schedule. So we will invite Dr. Tivika to present obstructed infected system and stones in the pregnancy. Over to you, Tivika.
Yeah, I'm going to talk about the management of obstructed system and the management of stones in pregnancy. So first, I will be talking about the management of stones in pregnancy. So as we know, the urolithiasis is one of the most common cause for admission in admissions of pregnant patients with abdominal pain. So the reported incidence of urolithiasis is about 1 in 200 to it can vary from 1 in 4,000. So, and usually they get admitted during the second or third trimester because that is the time the that is the time where they have the less chance of passing the stone spontaneously. And this is again a diagnostic challenge. Is a diagnostic the diagnosis would be challenging because there would be some we have to consider other differential diagnosis and other causes for abdominal pain. So the why it is important in pregnancy is because there are problem associated with urolithiasis as well as procedures done for the urolithiasis. The problems are there is a risk of miscarriage, sepsis, recurrent UTI, and it can cause perinephric abscess, and there's a risk of acute kidney injury or chronic injury if it is a long-term obstruction, and there's also a mild risk of preterm labor. So already the previous speaker has talked about the pathophysiologies. So when we consider the pathophysiologies, we have three main theories: the fixed particle theory, free particle theory, and the inhibitor theory. So fixed particle theory is when there's a nidus, it can precipitate the stone formation. The free particle theory says when there's a supersaturation of a particular chemical, again there's a risk of stone formation. And the inhibitor theory, it's a balance. So stone formers and the inhibitor. So when there's a distributions in the balance, again it can precipitate stone. In addition to these general the general theories and the pathophysiology, pregnancy also per se there's increased risk of urinary stasis, and there's hypercalcemia, physiological hypercalcemia in pregnancy, and there's decreased ureteral peristalsis because of the progesterone, and there's what we call there's something physiological hydronephrosis that can be caused by progesterone, or even the gravid uterus also can cause obstruct compression and hydronephrosis, and they are also at risk of infection due to the pregnancy induced diabetes and all. And as hypercalcemia also can cause increased urinary calcium excretion. So because of these reasons, again, there are it can also add to the pathophysiology. But having said that, it's only that they are not at higher risk of stone formation, but they are even because inhibitors also increase during the pregnancy. So comparatively, they have slight increased risk of stone formation and incrustation. So how do we diagnose? The diagnosis is the typical urinary colic. They can present with flank pain, hematuria. But as I mentioned before, the diagnosis can be challenging because of this. The gravid uterus, they can have pain in upper abdomen, and we had to think about other differential diagnoses like appendicitis, even placental abrasion. So we had to think about other diagnoses as well. So when we think about urinary colic after the history and examination, then we move on to the investigations. Regarding investigation, the first line of investigation is ultrasound scan. So ultrasound scan, again, we all know, it's operator dependent. We can see the site of obstruction, the level of obstruction, but it might not show the stone. But it can visualize the associated complications such as hydronephrosis, hydroureta. In case of infection, we can see whether there's a perinephric abscess. And we had to remember there's a physiological changes in pregnancy also can mimic obstruction. There's a physiological hydronephrosis or hydroureta can be present in pregnancy. Then the second line of investigation would be MRI. So MRI urography will show the level of obstruction, and if there are stones, it can show the filling defects. So and these are the recommended investigations. But if we move on, if we are still not sure about the diagnosis, we can use the low dose CT. That would be the last option, but that should be done in selected cases if we think the mother would be benefited by doing it. So this is the problem of our radiological diagnosis, because they are the pregnant women are at risk of carcinogenesis and teratogenesis. So if we know the eugenesis period is after 8 weeks. So we at least the risk is maximum from 8 week to after 23rd week, the risk is maximum. And MRI also we can use, but again, it's a second line. The use of gadolinium is not recommended because we are not sure about the toxic effects to the fetus, and it can also cause nephrogenic systemic fibrosis. So treatment depends on the whether the diagnosis, whether there is a proven urinary colic, whether the patient is having obstruction, whether it's infected upper system, and whether we can manage conservatively or within some interventions. So always when we are managing the pregnant patients, we had to be liaise with the obstetrician, because it's a so it can cause maternal and fetal side effects. So conservative management is the conservative management is recommended in all uncomplicated cases of urolithiasis. And we can, when we are talking about the conservative management, we can start from the pain relief, from simple analgesic like paracetamol, codeine if needed, and NSAIDs. So NSAID, again, within 20 weeks of pregnancy, there's increased risk of miscarriage, congenital renal abnormalities. So within 20 weeks of pregnancy, NSAIDs are not used. Again, near the term also, there's a risk of fetal pulmonary hypertension and premature closure of ductal arteriosus. So again, near the term also, it is not recommended. What about tamsulosin? So tamsulosin, as we know, is a medical expulsive therapy. It is used in medical expulsive therapy. As in no other patients, we can use tamsulosin, but there's no any FDA proven randomized trial. So it's a off-label use. If it is used, it can be given for 10 days. So then all uncomplicated cases we are trying to manage conservatively. So intervention is needed when the patient is symptomatic or when the patient is presenting with complications. If there's no spontaneous passage, or if the patient is having intractable symptoms, or if the patient is having severe hydronephrosis, or when they come with spontaneous rupture of the calyx, or induction of premature labor, we can manage with temporizing method. The temporizing method can be DJ stenting or nephrostomy. What about any permanent definitive management? So usually we tend to manage pregnant patients as with the temporizing therapies, either DJ stenting or a nephrostomy. But again, ureteroscopy also has become a reasonable alternative. So we can, when during the second trimester, if there's a stone, we can do a ureteroscopy, and we can go for a definitive management, because we know the stents are also related to the other problems. Can cause recurrent UTI, it can cause stent related stent related symptoms, and it can also the patient will have to come for a stent exchange. And pregnant mothers, comparing to the normal population, they are at risk of stent encrustation. So if we are putting a stent in pregnant patient, we have to make sure that we are changing at least after 6 months. So there's a need for stent exchange as well. For the ureteroscopic, during the ureteroscopy, we can use holmium laser, or we can go for ultrasonic lithotripsy method or basket removal. These are all accepted. And PCNL, of course, it's not generally recommended, but if it should be done by the experienced surgeon and only in experienced centers. Again, shockwave lithotripsy, ESWL, is an absolute contraindication in pregnancy. This is all about the managing pregnant patients with the ureteric stones or obstructed system. So now I'm moving to the obstructed system. So when we are talking about the obstructed system, it can be acute obstruction or chronic obstruction. And now I'm restricting myself only to the obstructed system caused by the ureteric stones. I'm not going to talk about the other causes for obstructed system, because we are dealing with the urolithiasis. I will be talking about the obstruction caused by the stones. So again, when they can present with flank pain, it can cause because of the obstruction, it can cause the sympathetic activation and nausea and vomiting, and they can present with hemodynamic changes. If it is infected, they can present with features suggestive of sepsis. And as we all know, the obstructed infected system is a urological emergency. This is some little bit about the pathophysiology. So when there's obstruction, you can see the two charts here. So one is the first upper one is about the mean left ureteral pressure. The lower one is about the renal blood flow. So we can categorize, since the time of onset, we can categorize we can categorize into 3 phases, the phase 1, 2, 3. So in the initial phase, that is about within 2 hours. So in the initial phase, what happens when there's acute obstruction, or when there's obstruction, the proximal part will be congested, and there will be increase in the ureteral pressure. So the increase in the ureteral pressure will activate the production of nitric oxide and the prostaglandin E2. So prostaglandin E2 and the nitric oxide will dilate the afferent renal arteriolar vessel, that can increase the renal blood flow temporarily. So you can see in the phase 1, there's an increase in the ureteral pressure and as well as increase in the renal blood flow. But in the phase 2, this pathophysiology tends to diminish over time. So there's although increase in the left ureteral pressure because of this reduction in the production of this nitric oxide and the prostaglandin E2, in the renal blood flow tends to decrease. Again, in the phase 3, both ureteral pressure and the renal blood flow diminish, and the decline also the decline also, you can see the rapid decline. So this is the when we have to intervene. So if we have to intervene, we have to intervene in the at least in the phase 1. And this is about the unilateral obstruction. So what about the bilateral obstruction or obstruction in the single kidney? Again, more or less similar, but in the single kidney or bilateral obstruction, in the blood increase in the blood flow, renal blood flow is only modest, and there's a rapid decline. That is about the hemodynamic changes and the physiological changes. The functional changes, so depending on whether it's acute obstruction or chronic obstruction. If it is acute obstruction, there will be only functional change. If it is a chronic obstruction, it can cause anatomical changes. And there are something about, we have to remember when we are relieving the obstruction, especially in the single kidney or bilateral obstructed system, there are something called post-obstructive diuresis. So what's the cause of post-obstructive diuresis? Is because of the osmotic diuresis of the accumulated chemicals, and also because of the impaired tubular concentrating ability, and as well as because of increased atrial natriuretic peptide. These all can cause polyuria and so electrolyte imbalance, usually the hypernatremia. So we had to monitor the patient for dehydration as well as for electrolyte imbalance. So I talk about the pathophysiology. Now I am moving to the diagnosis. So diagnosis of obstructed or infected obstructed system is history and examination followed by investigations. Investigation, as we know, the UFR. UFR will show whether there is any evidence of UTI, whether there is any crystal. It might suggest, not always, it might suggest there is a stone, and whether there is a proteinuria or cast. And then we can consider when the patient is presenting with acute kidney injury, we had to do the serum creatinine and to check the estimated GFR. And also, if there's a kidney injury, by doing the fractional excretion of sodium, we would be able to differentiate whether it's a pre-renal, renal, or post-renal. And then ultrasound scan. So we talk about ultrasound scan. Ultrasound scan is operator dependent. So we can know whether the level of obstruction, and we can do some adjustments to the ultrasound scan, or we can do some modifications, such as we can combine with Doppler, or we can combine it with color Doppler. So if we are using the Doppler, if we are using the duplex Doppler sonography, by calculating the resistive index. So resistive index is the peak systolic velocity minus end diastolic velocity divided by the peak systolic velocity. So if the resistive index is more than 0.7, it is suggestive of obstruction. And again, by doing the color Doppler ultrasonography, usually there's something called ureteral jet. So ureteral jet is when there's an obstruction, the concentrated urine will be dense, but the urine in the bladder will be less dense. So when there's a ureteral jet, it might suggest there's an obstruction. So we can again have an idea whether they are by this resistive index and the ureteral jet, we might get better clinical idea. So ultrasound scan is about 80% sensitivity. So if we had to the ideal scan, then the other investigation is NCCT. So NCCT we know it's about 96 to 99 sensitivity for the stone detection, except the stone caused by the Indinavir. But the gold standard is the CTI view. So CTI view, again, we have the two phases. So three phases. It's an initially non-contrast initial phase, then the nephrogenic phase, and the delayed phase. But these all are for the not for the urgent obstruction. But if the patient is presenting with the obstructed infected part, we shouldn't delay any intervention. But the patient is presenting with only the obstruction, we can do this investigation. So MR urography also not much of if we have the CT urography, then MR urography is inferior. So nuclear studies. So if we are thinking any about other than the stones, like if the stone secondary to the pelvic reproductive obstruction, we can go for a nuclear study. And what they say, the technique, the DTPA scan is way better than the MAC3 because DTPA is predominantly excreted by the kidney. And again, nowadays we are using CT IVU, but if we then in the we can, if it is not available, we can go for a conventional IVU also. So moving on to the management. Management can be acute and delayed or definitive management. So acute management, when the patient is presenting with obstruction, of course we have to manage the pain. So pain management, again, we can go for a non-steroidal anti-inflammatory drugs if provided that the renal functions are normal. And again, we have to go for a prompt drainage. So prompt drainage, it can be nephrostomy or degestenting. And if in case of bilateral renal obstruction or obstruction in the single kidney, or when the patient is presenting with infected obstructed system, again, we have to go for urgent decompression. So methods of urinary drainage or decompression can be, as already I mentioned, it can be ureteral stenting or a degestenting or a nephrostomy. So there are pros and cons of each method. None is superior. So again, nephrostomy or degestenting has its own pros and cons. So when we take the ureteral stenting, again, the advantages are it's completely internal. So there's no need to go for it. There's no any external drainage that would be more comfortable for the patient, and it can be done in patients who have high bleeding risk. And but the problems are it would be challenging in reconstructed system, and in patients who are unable to be put on lithotomy, and if there's impacted stones, and if there's a complete stenosis or tumor infiltration, these are the technical difficulties. The anteroperant nephrostomy, the advantages are local. So even if the patient is presenting with shock and hypertension, we can do it because it's our local, and it provides rapid decompression because we can put up to the 10 French nephrostomy tubes we can put. So it relieves rapid decompression and better improvement. And the problems are again there's a need of external drainage bag, so it would be uncomfortable for the patient, and there are risk of bleeding, and there's a risk of dislodgement and risk of ascending infection. These are the problems with nephrostomy. So again, so none is superior. Both have own pros and cons. And so the definitive we have, when the patient is present with infected obstructed system, again we had to go for urgent decompression. And during the time of decompression, we had to take the sample for the cultures. So initially the management, actually the sepsis management, we had to follow the septic bundles. And the definitive management, the attempting definitive management, then the patient is presenting with infected obstructive system, again going for a definitive treatment is discouraged because because of worsening sepsis. So delay the definite treatment until the sepsis is resolved. Thank you.
Thank you, Divika, for the nice presentation. And now we will go for the expert opinion. Ranga sir and the Niroshan sir.
Yeah, Tivika, now if you want to summarize the challenges that you would encounter managing a pregnant lady coming with urinary colic, can you list them 1, 2, 3, 4 at your level?
The diagnosis would be challenging,
Yes,
sir, because
good. Diagnosis is challenging, correct. Yes.
they can present with atypical presentation. Yeah. And then again, going for a confirming our diagnosis, so we can go for we can't go for ideal investigations like NCCTO, but
yes. Right.
again, so we had to limit ourselves in investigations. And then so we had to exclude other differential diagnoses also.
Yeah, that's
and
all about
then,
diagnosis. And then
and then we had to liaise with the obstetrician, because there can be, we had to think of, it's not only the mother, we had to think about the fetus. So we had to make sure that the fetus is live, and the fetus also, we had to get the VOGT review. And then,
So
sir,
basically, you
we
have
had,
two components: managing the mother, managing the baby.
yes,
And then your issues are, one is a diagnosis, and then how to treat. Even the analgesic treatment could be challenging because you have no free arm to decide on analgesics, these patients, and whether to intervene or not to intervene. And if you are going to intervene, when to intervene and what to do. Those are the basic challenges that you need to, as you correctly mentioned, that you need to tackle. And one little question about obstructed system, the stenting versus PCN. What is the most likely deciding factor in our setup?
the availability of the radiologist.
Yeah, either availability of an interventional radiologist or the urologist. So that is the main deciding factor in local setup.
Urologists are always available, sir.
Yes. and then that will mostly decide as what to do. Anything, Nirosh, you want to add anything?
Yeah, Tivika, nice presentation. Few practical things now. The one thing is pregnancy and stone. When the patient is referred to you, after listening to your presentation, you would also not know what to do definitely, and you end up in a symptomatic patient. So, in practical terms, provided your facility is available, first thing is you have to make a firm diagnosis. Otherwise, you are not going to enter. Do some surgical intervention for this patient, because the patient is coming because of the failed medical management. Okay, so in my practice, what I do is I have a very low threshold to do MRI, because these patients are pretty demanding, number one. Second thing, in terms of practicality, what will be your main objective in treating the patient? When the patient comes, considering all what you have said, what is the main objective of treating? Now you have decided to do the surgery. So what will be your main objective?
We had to treat, the aims are treating the symptoms and to prevent the complications, because they can come with UTA and sepsis.
Now what is the treatment? I'm telling you, what are you going to practically do? There is a stone, 8 millimeter lower ureteric stone. Okay. You can do many things, but what will be your main
if the
thing?
patient is symptomatic, sir, I would put a DJ stent.
Yeah. So
And then
main idea is you go with the plan to put a stent and decompress the system. That will be the main thing, right? So practically, though the stone is low, you might think you can get away with a URS, but it is not so, especially when the patient is in the 3rd trimester. It's very challenging. And you must ensure correctly that, as you quite correctly said, that you need to liaise with the obstetrician. But these patients can go to premature labor. So there must be sometimes a neonatal support. If you are not having a neonatal support, thinking it's a lower ureteric stone, you go and do stone fragmentation, you might end up in trouble. So the safer thing from if you don't have support is to put a stent and get the patient relieved. And then if she further has complications or anything, then you get the to a place where the facilities are there. So primary objective should be to decompress the system. Okay. Yes, as you quite correctly said, the practically keeping the stent is not possible for long term if they come in the early part of the 2nd trimester, or if at all these patients who are on stent get pregnant and then they come to you. Now you are worried whether you need to remove the stent because stone encrustation, infection, and so on. But you need to analyze these things case by case, but generally the stent will be there safely for during the pregnancy. So don't go in the conventional thing, but you need to analyze all those factors, but don't do unnecessary interventions if you need. Okay, so next thing is obstruction infection system. As you quite correctly said, you need to have a very low threshold to stent them. Okay, unless they are very septic, not suitable for a GA, provided you have radiological support, then you can get a PCN. But main thing is to not to give antibiotics and wait and so on. And most of the patients will be coming from the medical wards. They're bombarded with antibiotics. So just put a stent and try to decompress. Those are some of the practical things I want to tell you.
And Tivika, just to add to that, and the other thing is the emphysematous pyelonephritis. It's a very common condition with poorly controlled diabetics. Even without significant hydronephrosis, still there is a place for decompression and then the placement of a stent. That's number one. Number two, the commonly what I see is the poorly controlled diabetics coming with obstructed infected systems. When you do the CT, there is no stone. Common interpretation of the radiologist is possibility for recent passage of a calculus. What do you think about that?
Papillary necrosis, we had to think about.
Yeah. So don't go after the stone. If it is hydronephrosis, still there is a place for stenting. Probably we have encountered so many patients with papillary necrosis, and then there may not be a stone, but if you just wait and see, looking for a stone, probably you can lose the patient. Don't forget about the papillary necrosis.
I totally agree with Ranga on that last point, because this is a common mistake done by most of the physicians, because now because the urologists do first line CT for stone diagnosis, now they do CTs by themselves for the first line, and they keep on giving antibiotics for long time. But when the patient becomes septic and not treatable, then they refer us. Then the first thing is you put a stent, and they rapidly improve. Okay, thank you.
Okay, Tivika, thank you.
Thank you, sir.
Yeah, I think the other few critical points would be the side of the hydronephrosis, another common thing which can be asked. So, Tivika, which side you would prefer to have the hydronephrosis in a pregnant patient? If it is, are you worried in a right-sided hydronephrosis patient or left-sided hydronephrosis? You still there?
I think the right side is anyway the physiological wise common. So left side is we had to think about.
Yeah, if it is left-sided, you are much more worried because right
Yeah.
side is yeah. So
I have seen this referring mainly they refer for right sided hydronephrosis.
yeah, and the other thing is it's true that you need to put a stent in a pregnant patient. They come with infection and obstruction, and if the creatinine is high, and also if the pain is uncontrolled, but then you have to do this without most of the time without the C-arm guidance, unless if it is like late third trimester. So it's a bit of a blind stenting. So that is also a practical point. You remember that also in a situation, if it is a scenario, you need to mention that also. So that's just a practical point to remember. I think we can move to the next speaker now.
Thank you, sir.
Thank you. And then we would invite Dr. Nabil from Kandy, and he'll be presenting about the management of renal stones. Over to you, Nabil.
I'm Dr. Nabil, SR in Neurology and Teaching Hospital. Today my topic is regarding the management of renal stone. And because most of the topics in the pathophysiology and the classification of renal stone, as well as obstruction, the Niranga and Tivika have discussed regarding some of my points, which is some included in my topic as well. For in epidemiology, usually whatever the things already discussed, geographical and climate and ethnic and dietary and genetic factors, which will determine the prevalence of the disease, mainly the renal stone. Usually around the world is around 1% to 20% according to their the factors which will determine. Right. Then when the presentation of the renal stone and considered, usually more symptoms patients are the one who's presented the ETU as well as in the emergency setup, and some are incidentally finding for the other investigation while they are for evaluating for another cause. So, and other things, pain and hematuria as the common as the presentation. Hematuria usually they will be present with the microscopic, and with not notice. Sometimes they will present as a gross hematuria very rarely with the renal stone. So, histovae stone usually they will present with the recurrent UTI and loss of lethargy, fatigue, like infected pyelonephritis or perinephric capsules. They can present as an initial presentation with histovae stone. And less commonly, the histovae present with this kind of presentation like pyelonephrosis and perinephric capsules and xanthomatous pyelonephritis, because almost the kidney has gone with the effect. System has long-term stages of this stones. And the traditional indication for the intervention are mainly the pain and infection and obstruction. And the hematuria caused by the stone is only very rarely and frequently enough to be the reason to warrant treatment. So all the kidney stone not necessary to treat. So usually I have all the these diagnostic modalities which are discussed in the Tivika's notes, because usually this mainly the focusing, even though laboratory investigations some are supportive. Mainly our diagnostic things are mainly X-ray, ultrasound scan, and the NCCT KUB and IVU and CT urogram are the, which has been considered most with the renal stone disease, where the X-ray KUB have sensitivity around 70%. Most of the radio density stones are detected around 70%, and the 90% of the radio density stones. In the ultrasound scan, around sensitivity depends on 45 to 80% among subjective variants. With full bladder and proper preparation, we can detect it. But with a combination of X-ray KUB and ultrasound scan, some have good comparable to the NCCT KUB. That's what they have described in the literature. So sorry, 90 to 95%, 98% around with the NCCT KUB sensitivity. So only the Indinivia stones which cannot be detected in the NCCT KUB, which is already mentioned, and which can be detected in the CT urogram besides the filling defects. So otherwise, others are usually nowadays are not practicing too much on the in our current setup. So management of the renal stone, we are considering the conservative management when the renal dissolution of the stone and some intervention, where all things are depend on the stone factors and the patient factors and the surgical preference of the patient from the surgeon side. So whenever the conservative approach means asymptomatic renal calculi, where most of the time it is less than 5 millimeter, and it's a remaining static size, not progressing, or medullary spongy kidney with the tubular calcifications, which is long lasting and can be, we can follow up in the scan, X-ray or ultrasound scan, or CT with a 6 monthly, then annually, with a follow-up manner for a conservative manner for the asymptomatic stones. So when we come about the intervention, so most of the decompression things are discussed in the Tivika's presentation, where the obstruction, which can go the renal stone or pelvic stone, sometimes some chelicosis and localized obstruction and generalized PUJ obstruction can cause by this pelvic stone. The PUJ level it can come and obstruct and causing the acute complications, infective complication as well as acute renal failure, where we need interventions. So when we consider the acute decompression, already discussed the obstruction with sepsis or renal failure, where we have two options where the ureteral stent or percutaneous nephrostomy. Both are equally effective, which I have already discussed, the pros and cons. And so this I skipped these slides. So whenever consider the active management, the progressing stone size, these were the stone factors, and when there is obstruction or infection or persisting pain with the medical management, not respond to the medical management, or other things, social situations where patient have a pilot or a deep sea divers, or in occasionally even a small stone, they can't because do their work, because that is the critical situation to all the passengers. And as well as the person we are deep divers, usually they have risk of in deep sea where they can get this colic and get problems. So in the social situation and their profession, we have to consider, as well as the patient request, we will decide on the management point. Mainly the stone factors and the person factors are the most considered, these are the other factors which will determine the active management of this patient. So when we consider about the renal stone, we have to get the idea with the EU guideline, with the algorithm. Usually the size factors and the place, location of the stone, which will determine our choice of management priority. So whenever the kidney stone, except the lower polystone, but all stone, kidney stone, but consider the lower polystone, 10 to 20 millimeter size included. Considered where the more than 20 millimeter, 2 centimeter size stone. First consideration is a PCNL, where we can consider the second line as even RIRS, flexible ureteroscopy, or ESWL. When in between 10 to 20, where we can consider the ESW as a first choice, the renal pelvic stone, upper calicary stone, or middle calicary stone. In the lower calicary stone, if it is favorable, that is the where 10 to 20 millimeter. Less than 10 millimeter, the stone size, you can consider the initial way where ESWL RIRS will determine. RIRS and ESWL will be the first priority. Then, if it is not settled or not responded, we can consider the second line option as a PCNL. That is their recommendation. So, it's a low polystone which is more than 20 millimeter or less than 10 millimeter, where we have optional things. In between, with that 10 to 20 millimeter size stone, where unfavorable factors for ESWL. Yes, if it is means it is not favorable for ESWL, consider the PCNL or RIRS. If it is favorable for PCNL, it means even if in the low polystone, in between 10 to 20 millimeter, even if it is size around 2 centimeter, we can consider the ESWL. So that is the EU recommendation. So this is the literature review I have gone through, where the stone-free rates for the lower polystone in the PCNL versus ESWL, where the less than 1 centimeter stone, where the PCNL have 100% stone-free rates. And when the ESWL comparing ESWL, 63%. So in a stone size 1 to 2 centimeter, PCNL have a 93%, the stone-free survival, and the ESWL goes to 23%. So the very much reduction it has shown. So more than 2 centimeters, it has gone up to 14% in the ESWL. So the PCNL have a comparable results when compared to ESWL. When the size of the stones increasing is more than 2 centimeters, more recommended ones are the invasive endourology, where the PCNL the more beneficial. That's how they have cleared for the lower polystone. And other studies which have comparably flexible ureteroscopy as well as ESWL and PCNL, according to the size of stone, they have chosen one less than 1 centimeter stone for a ESW and flexible URS, where it's still the ESW will have a low stone-free rate compared to the flexible URS. It is ESW around 35 to flexible URS around 50%. But in the higher the size, 1.0 to 2.5 centimeter, where flexible URS comes around 37, but in the when compared to the PCNL, it has gone around 71%. It means good PCNL have a good overall stone-free rate. So my consideration here with some topics about the procedures where the ESWL, where the technically attempts to break the stone externally, focus the high intensity acoustic pulse, the focus manner, where the treatment available initially, the only treatment available for stone, which didn't pass spontaneously, which is the only surgery. But the ESWL came to place, where then we have a minimal invasive method, which has progressed for a stone disease, a stone break clearance era. So used for renal pelvic and calicary stone, ESWL, and upper ureteric stone and mid ureteric stone, those will be, I think, probably the discussing in the ureter stones in the other topic. And which can be minimal analgesics and intermal analgesia as an outpatient procedure. We can do this in the selected patients. So this is spent fragmentation mechanism, and this can be several methods. There are so many instruments which is using the different kind of modalities. I don't much go in details. So the main thing is where the initial compressive forces targeting for to the stone, where the density difference is will determine, and after releasing this, we have a tensile forces and cavitation forces which will break the stone and which will give the fragmentation results. So which will determine this the patient habitus and the efficacy of the lithotripsy, as well as the size and the location and the composition of the stone. So when the stones skin to stone distance have moved, it's a less chance to be break down is more than 10 centimeter negative effect in success rates. So patient decision is obese patients better to not much obese, morbid obese and very obese patients, better to choice not the good option for ASW. The efficacy of the newer generations are better and good results in the lithotripsy. And when compared to the size, I have already mentioned less than 20 millimeter to less than 2 centimeter in the upper pole and middle pole, and the renal pelvic stone have a good outcome compared to the lower pole. And the compositions where it has less than 850 composition, according to the characteristic of the stone, which will determine for the breakdown. Otherwise, more density, more than 1000 and 1200, it will break down is when comparably less, and the stone free rate is less. So ESW not recommended for more than 2 centimeter Steg-Horn calculi or stone associated with abnormal renal anatomy. So some relative and absolute contraindications are there. You have to consider before considering the ESWL. So when there is a sepsis, urosepsis, uncorrected coagulopathy and pregnancy and uncorrected distal obstruction to the stone or aneurysm in the vicinity, where the absolute contraindication to go with the lithotripsy, the ESW. So when there's a relative where the body habitus, morbid obesity and orthopedic and spinal deformities and renal malformation and poorly controlled hypertension and the renal insufficiency, those are relative contraindications. There are some causes, the cardiac arrhythmias and patient wants oral anticoagulant should be discontinued, and the aspirin and NSAID should be stopped 7 days before the treatment. So those are the cautions which I have to take before giving the extracorporeal lithotripsy. So studies wise, the stents in ESWL we have to think of. So what is the role play? So in internal, it helps to internal drainage and reduce the renal colic and obstruction, allow passive dilatation of the ureter. But there is no stenting does not improve the stone free rates, and it does not reduce the stent striae and chain of stone in the column, or reduce the infective complication. Does not reduce. So it will not much beneficial when compared to stent with ESWL or without stent. Now no one recommending before stent before ESWL. So post ESWL, following procedure, the pains and the flank hematuria and the passage of stent fragments, those are advices has to be given. That is common, which will require the patient education and oral analgesics and medical expansion therapy, where it can be blocked in the ureter, where it can cause pain, and we need a tamsulosin or a pain relief treatment for supportive management of these patients. So these are the complications, where most of the things are mainly minimal bleeding, but some patients can get the perirenal hematoma, subcapsular hematoma, or intrarenal hematoma is also possible as a severe complication, but it can be managed conservatively. In a persisting bleeding or in things, sometimes very rarely, they need interventions. And severe flank pain due to this infective hematoma and bleeding complication. Other thing is stone can block and causing infective complications. And more the other thing, tissue traumas, adjacent tissues, which can also give rise to infection complications. So other thing, what I have discussed about this percutaneous nephrolithotomy, where we have to select the patient the more than 2 centimeter, mainly for the Steg-Horn calculi and ESWL resistant stones. Those are the patient selections where we consider for the PCNA. And contraindication, where patient on anticoagulation, we can even go ahead, but on anticoagulation we can't control, so we have to make it sure. untreated UTI, and there is underlying malignancy, and pregnancy is the contraindication for nephrolectomy. But nowadays we can do the ultrasounds and these things, and this can be changed with time. So other things, planning about the imaging modality is a very important preoperative planning. PCNL must obtain, because CT IBU is better option, because we can get this pyelogram, the evidence of mixed delayed phase, where we have get the idea about the calyceal system and the drainage system, and the stone positions, and the where to puncture, and the distance from the skin to the kidney site, and where to puncture. Everything can be planned. And the procedure wise, I don't go into detail, but we can do in the mainly the supine or prone PCNL, both nowadays practicing. Prone is one which I have already practiced, now is changing towards the supine. In the prone PCNL, where most of the centers we are practicing up to 30 French kiss dilatation and impulses technique, and it may be a gradual dilation, or it may be a single step dilation, or it may be down mini PCNL and coming with the high laser powers are coming into place, and which have overcoming even the minimal complication of this system. Other thing is it may be a tubeless or tube, or with stent or without stent, according to the preference of the surgeons. So post-operatively, where it can cause, we have to educate about the patient, about the mainly the patient get bleeding and perinephric collections, and urinoma formation, and leakages, and sometimes residual stones, and can obstruction, and may need stenting, and infective complication, mainly the sepsis and septic shock. Patient may be need ICU care. So these things are the one which can post-operative complication related to the nephrolectomy. Inadvertently, we can injure the bowel as well as the pleura, or the liver, as well as the spleen, or the adjacent organ. Even it can damage. So those are the things which can happen in the post-operative, as a post-operative or intraoperative complications. So mainly other retrograde intrarenal surgeries, we can consider the flexible ureteroscopy and laparoscopic nephrolithotomy and open surgeries. These are other options when there is a with this ESWL, or unable to go ahead with the piece about the instrument, and no approach available because of the availability. And we can consider the open method like a nephrolithotomy and open extended pyrolithotomy. Sometimes the kidney function poorly function due to the long-standing renal stone, we need a nephrectomy even. So the indication for the flexible ureteroscopy, where the ESWL failure and lower pole stone with reduced stone purchase is less likely, where the ESWL, where the lower pole stone, which is more than 1 centimeter, and the infundibulous angle, and the width of the angle, and the, that will determine the passage of. In failure, we can consider. And cystic stones, yes, they are considering, because they are more dense stone, ESWL not amenable. And obese patients at PCNX is technically difficult. Even we can consider this patient for a flexible ureteroscope. And technically difficult patient, other muscular deformities, and the stone calyceal diverticulum, stone in the calyceal diverticulum, those are the main indications. And if it is available, we can consider the flexible ureteroscopy. And usually that is less invasive compared to the PCNL, even mini PCNL. If it is technically amenable and we can proceed, if it is available, we can go ahead, but costly, and other train about the RIRS is the issue which come when go with this flexible ureteroscopy. So open surgery, where we can do the complex stone burden, where the multiple stagone calculi, and really we need a multiple puncture to go ahead with the PCNL. And in those considerations, we can do open surgeries, but even nowadays we can practice even stage procedure as a PCNL even. So anatomic abnormality that preclude endoscopic surgery at retrorenal colon also we can consider, but we can do it even in the laparoscopic mobilization. After that, we can do even PCNA. So even gross obesity and kyphosis, the other anatomical abnormalities, even we can consider the open surgeries. So otherwise, patient request or if they non-functioning kidney, we can go into the open surgeries. So those are the treatment modalities which are considered. I have already discussed about the algorithm, and this is the where we come into the chemolysis in the renal stones. We are mainly the uric acid stone and the cystine stone. Where we consider the dissolution of the stones. We can without treatment, it will go into size and they will disappear. So it mainly the treatment option wise, high fluid intake and potassium citrate for urine alkalization for the uric acid stone. And we can treat if underlying causative like metabolic gout and allopurinol treatment with 100 milligram daily, and dietary modification where the low protein diet and high water intake. Those are the main concerns because Western style people have more high dietary protein as well as fluid intake where they have uric acid stones are more prevalent, more compared to here. So dietary modification which will have help to the uric acid formation reduction. And cystine stone, we are seeing dietary modification where the cystine containing amino acids, this amino acid containing foods, which will reduce the cystinuria in the which can form the cystine stone. And we can go with the high fluid intake and urinary alkalization. As a treatment, we can give the penicillinamide and acetyl penicillinamide and metacaptopropioniglycine, which is as a treatment for this can convert this cystine formation reduction. So these are the modalities which can give as a dissolution therapy and intervention or the conservative approach for the renal stone. So take home message where the stone size and the location and composition and renal and patient habitus and the patient choice are important factors in determining optical treatment modality. Percutaneous nephrectomy is a procedure of choice in the treatment of large stenochondral stone more than 20 millimeter. Stone size 10 to 20 mm can be approached using ESWL non-lower pole and RIRS or PCNL. Stones smaller than 10 mm are usually treated with ESWL. If they are in lower pole with unfavorable anatomy, RIRS may be suitable for alternative. In a special situation where RIRS may be difficult, imaging techniques as mini or micro PCNL may be an alternative. Thank you.
Thank you very much, Nabil. Your descriptive and nice presentation. And we will move to the expert opinion first. Niroshan sir, Ranga sir.
Yeah, Nabil. Few things to tell about this now. I know you are focused on the EAU guidelines and the other published guidelines, where the stone size and the mode of treatment is basically they are going by the size. But now remember, most of these guidelines, they are mainly talking about the standard PCNL.
Yes,
and just a small correction, now in the current practice, we don't dilate even in the standard PCNL, we don't dilate up to 30. Usually we stop at 24 now. But you can go up to 30, that's fine. Looking at the standard PCNL, they talk about this 2 centimeter and 1 centimeter, all these sizes. But one should not forget all these miniaturized systems where the mini PCNL and the micro PCNL and ultra mini, all these things, sometimes even a 6-7 millimeter stone in the lower pole may be dealt with these PCNL variants.
Okay, sir.
And the other thing, I'm not quite sure, you mentioned, I don't know whether it's in the guidelines, the CT urogram is recommended before a PCNA?
No, recommended means CT urogram will give a delineation of the anatomy because we can see a calyceal system and and the pelvic area. We have
correct.
idea.
Maybe only for the selected cases. Most of the cases, there's no issue in the non-contrast CT. You can identify the anatomy and then go. But if you have a doubt and you are not quite sure about where the stone exactly and all, then
Yes.
probably in selected cases there is a place for CT urogram. But
Yes, yes.
not as a general rule.
Yeah,
Contrast CT is good enough.
Yeah, non-contrast is a recommended one. And I have mentioned about because it
Yeah, and just a small correction. Now, when we assess the split function to confirm it's an unfunctioning kidney, mostly we use the DTP in this country than the DMSA. DMSA is basically for the scarring purposes. And in the Western world, remember, it's a MAC3 renogram, which is superior to your DTPA.
sorry.
Anything else to add, Nirosh?
Yeah, I think you covered most of the thing, and you quite correctly, this Ranga told that contrast CT is not indicated because you have. Hello, can you? Yeah, if you are embarking on a PCNL, anyway you're doing a RPG, so that will show the anatomy. One important thing to note that is, have you seen patients put for shockwave lithotripsy without a CT scan? Have you encountered patients coming back to you with that?
Usually for the ESWL, we are not doing the CT as a first line. We do X-ray, sir. We go ahead with the ESWL amenable or not, and the other contraindication, if it is not there, we can consider directly for a ESWL. But routinely we are not practicing on the patients because of the unavailability and the stone, the prevalence. Those are high. We can't go to the CT, sir. That's we don't do all patients with the CT, sir.
Yeah, so with time you will realize shockwave lithotripsy is one for you to bail out patients coming and insisting on surgery. So that is a wrong practice. Okay, so if you are putting a patient on shockwave lithotripsy, you have already put the evidence and the guidelines that these patients need a definitive understanding of the stone composition and the anatomy to put the patient on shockwave lithotripsy. So that is wrong practice, and don't do it as a bailout procedure. Secondly, said that PCNL is indicated in shockwave lithotripsy resistant patients. What is your criteria? How do you define shockwave lithotripsy resistant?
Resistant means usually in practice usually when we consider about the radio density, usually you have to ideally have to Hornspiel assessment has to be done, but in the X-ray we can see some radio density wise, and the poor radiolucent one we will decide and give our 3 or 4 ESWL if it is still actually they have given only 2,000 socks, but not considered as a 4,000 as a standard. But if it is not breaking down, or if it is not settling, that we will consider as a actually the definition wise resistant. I don't know, sir. Actually, but our practice we are doing the 3 or 4 SW, and we consider put into a invasive, minimally or invasive procedures.
So the number of attempts you try on the patient is just only one factor. If you put a patient on shockwave lithotripsy, after the initial impact lithotripsy, you need to assess whether this patient has some benefit from that. And if there is no evidence on radiological benefit, and also if the patient has developed complications such as massive hematuria and new onset hypertension, which are absolute contraindications because that it is a significant renal injury following the initial. So you need to think on plan the next step of shockwave lithotripsy, considering the number of shock, the ramping methods, and the localization, the angle. All those factors have to consider for the second go, rather than just repeating what you have done initially. So those are some of the things, and general consensus you are not, if the stone is not breakable in 2 or 3 goes, then you should consider this is a shockwave lithotripsy resistant stone.
Yeah, Nabil, quite correctly, as Dr. Niroshan said, the CT is essential before ESWL because a lot of factors. One is density. If it is 1,500 Hounsfield units to begin with, you never think about ESWL, number one. Number two, if it is a lower calyceal stone and then you look at that, there's a long calyceal neck and a narrow calyceal neck, obviously you will not be thinking about ESWL.
Yes.
Yeah, so I think it's, I mean, bottom line, if you plan to intervene, I think all these patients should have an ideal setup. They should have an uncontrast CTKUB before we
Yes, that's
plan
true,
for
sir.
any intervention. For the exam purposes, I'm telling you, right?
Okay.
Nabil,
Yes.
Nabil,
Yes.
in your presentation, there is a lack part is there. That is, you didn't mention about any studies comparing ESWL, URS, and the PCNL. Do you know about the studies?
I have made, I have gone through this BJ knowledge, and I have taken the studies names. I forgot, sir. I have mentioned about the studies, and they are the stone-free rates with the standard PCNL comparing this flexible ureteroscope as well as ESWL, which they have given. I have come across in my presentation, sir.
Yeah, this Uromet, the
Yeah,
ultimate
but not
purpose.
mention the names of the studies, but
Nabil, this is the thing. Our purpose is to maintain
Hello,
the
sir?
Uromet for exit exam. So when you come to the exit exam,
Yes,
you have to come with the level 1, level 2 evidence. And when we compare the evidence, come to the evidence, you have to mention the few names related to the study. So lower pole 1 study, lower pole 2 study, and the PO study. So you have to go through those studies
Yes.
and mention about the names as well. So it will shows you are confident, and you have to read more.
Yes.
Because we are targeting the exit
Okay, sir.
exam, because we compare to other countries. When you go to the abroad for the foreign training, you will realize so how much of knowledge lack in our part. So that is why we conduct in
Yes.
the Uromet session. So otherwise, no point of doing the weekly base or the monthly base this teaching sessions. So everybody should go through the studies as well.
Yeah, at least key studies you must be able to mention, Nabil. Everybody, for the purpose of that, the key studies, there are landmark studies that you should know and you should mention.
Yes.
That is important with the
Okay.
names.
Shall we move?
Yeah.
Yeah, I think we can move to the next one. Yeah, Monipriya quite correctly said you need to know. I mean, when you talk about the renal stones, we need to mention about the low pole 1 and low pole 2. Although they are a little bit sort of kind of almost little obsolete, those are the only randomized sort of trials that we have. Remember, but at the same time, I think you have sort of given the data on the low 2 study and the 1 study. Remember, these were done around early 2000s, right? So nowadays, the flexible ureteroscopy is much well developed. So the updateness and the most up to date I mean, the flexible ureteroscopy modalities will be much more effective. So keep that also in the mind, but you need to mention, quite correctly said, you need to mention these are, because these are the sort of very key papers. There's nothing much in the stone module you need to remember. You need to remember a few studies, but you need to sort of mention them and establish your facts. We'll go to the next and the last speaker, and that will be Dr. Balakrishnan Prageladhan. Sorry, Prageladhan. So he will be talking to us about the management of ureteric stones. Over to you, Balakrishna.
Thank you, sir. Can you all see my slides, sir?
Yes, we can see.
Good evening to you all. I'm today going to talk on the specific stone management of the ureteral stones. So the ureteric stones are the common cause for the emergency presentation to the emergency department, and the urinary stones affect about the 2 to 3% of the population and have a slightly male predominance. The peak age of the presentation is between the 40 to 60 years in the males and about late 20s in the females. So once the patient has a urinary stones, they have a 50% chance of recurrence and about 10% reoccur within the first year of life. The typical presentation is a sudden onset of loin to groin colic type pain, and the stones at the VGJ can cause the storage symptoms of urinary frequency and the urgency as well as dysuria. And also they can present with the pain which radiates to the tip of the penis or vulva. Sorry, sir. Hello, sir.
Yeah, I think go ahead. We had some disturbances. I think now it's settled. Please go ahead.
Sorry, sir. Can you hear, sir?
Yeah, we can hear you. You are very clear.
Okay, sir. The stones tend to obstruct at the three narrowest points in the ureters. One is the pelvic ureteric junction, then is the where the ureter cross the iliac vessels near the pelvic ring, and then at the vesico-ureteric junction. The urinary analysis is a facility for the blood. It can be about in a 93%. It can be a microhematuria. So the diagnosis, and the previous all speakers are they speak about the imaging modality. So the NCCT-KV is a gold standard imaging modality. So in addition to the identification of the stone, we can assess the size of the stone, location, and the density, as well as the associated hydrogelutar nephrosis and the skin to stone distance. So this is a EUA recommendation. So the imaging, the immediate imaging is indicated with the fever, solitary kidney, and when diagnosis is doubtful, and the use of non-contrast CT to confirm the store diagnosis in patient with acute flank pain following the initial ultrasound assessment, and perform the contrast study if the stone removal is planned and the anatomy of the renal collecting system needs to be assessed. So the diagnosis is the metabolism related. The stone analysis should be performed in all first-time stone forms. In the clinical practice, repeat the stone analysis is needed in the case of recurrence under the pharmacological prevention, the early recurrence after the interventional therapy with the complete stone clearance, and the late recurrence after the prolonged stone repair. The preferred analytical procedures are the infrared spectroscopy or the X-ray diffraction. This is a year recommendation, and the previous speaker has spoke about it. So management, the chief determinants of the stone passage is the diameter of the stone in its transverse orientation. The surgically treated ureteral stones consist of 4 minimal invasive modalities, including the software lithotripsy, URS, PCNL, and the laparoscopic or robotic assisted stone surgery. The open ureteral stone surgery is rarely performed. Access to the minimally invasive modalities exists and is often reserved for the instance in which less invasive options have failed. So optimal treatment depends on the stone-related factors, clinical factors, and the technical factors. So the stone-related factors are the location, size, composition, and the degree of obstruction. And the clinical factors are the symptoms, severity, patient expectation, associated infection, solitary kidney, the abnormal ureteral anatomy, coagulopathy, and obesity, and the technical factors and availability of the equipment and the cost. So the conservative treatment, so the initial management of the most ureteric stones, and we can give the analgesic and antiemetic, and the hydrations are no benefit from the forced diuresis, and estimated that about 90% of the stones up to the 4 millimeter pass within the 40 days. The spontaneous stone passage was reported about 49% for the upper ureteral stones, about 58% of the mid ureteral stones, and the 68% for the distal ureteric stones. Considering the stone size, almost 75% of the stones less than 5 millimeter, and the 60% of the stones more than 5 millimeter pass spontaneously, with the average time to stone expulsion is about 3 weeks. These are the studies are regarding the spontaneous passage of the stone. If the stone, most of the studies regarding the stone size less than 5 millimeter, the number of percentage of stone passing is about 80 to 90%, and the stone size more than 5 millimeter, it's about the 40 to 60%. Then the ureteric colic, the pain control, the NSAIDs are very effective in treating the renal colic superior to the opiates, and offer the renal decompression of the URS stone removal in case of analgesic refractory colic pain. There are Cochrane reviews looking at the use of NSAIDs for the management of acute renal colic. So both NSAIDs and opiates were found to reduce the patient-reported pain scores. But the study says that opiates were associated with the high rates of vomiting and hence had a greater side effect risk. For the patient with the ureteral stones that are expected to pass spontaneously, NSAIDs tablet or the suppositories may help to reduce the inflammation and the risk of the recurrent pain. This is a year recommendation. So for the non-steroidal anti-inflammatory drugs as a first drug of choice, they offer the opiate as a second choice, and the patient with the refractory pain due to the NSAIDs, we can consider that decompression with the stent. Pharmacological treatment is with the medical expulsion therapy. The treatment should be discontinued if the complication develops: infection, refractory pain, deterioration of the renal function. In the case of non-uric acid stones in the distal ureter, combination of alkalinization with the tamsulosin can increase the frequency of spontaneous passage. The common drugs are used as a medical expulsion therapy. These are the alpha blockers, commonly the tamsulosin, also the tamsulosin, and the calcium channel blockers, nifedipine, NSAIDs, steroids, and the phosphodiesterase 5 inhibitors. Is a EU recommendation. So the greatest benefits might among those with the more than 5 mm distal ureteral stones, and the alpha blockers increase the stone expulsion rates in the distal ureteric stones more than 5 mm. The EU recommend that consider the alpha blockers as a medical expulsive therapy as one of the treatment option for mainly the distal ureteral stones. So the other benefits of medical expulsion therapy, so reducing the pain episodes and the reducing the analgesic requirements, reduce the stent-related symptoms and the beneficial in associated drugs. The caution should be considered that it can cause the hypertensive episode, retrograde ejaculation, floppy syndrome, sulfonate hypersensitivity, and the pregnancy. We need to caution about the pregnancy and the breastfeeding and the children. There is a EU recommendation. So for the obstructing uric acid stone, combination of the oral chemolysis with the tamsulosin is more effective than each substance alone, particularly in stones more than 8 mm. The previous speakers has already talked about the decompression. So when we need to consider the give up conservative management if the non-progression and the severe recurrent colics and any signs of sepsis and the signal kidney or CKD, bilateral calculi, we can the decompression with the ureteral stents or the PCA. So EU recommendation for the decompression. So the indication for the acute removal of the ureteral stones. Stones with the low likelihood of the spontaneous passage and the persistent pain despite adequate analgesic medication, the persistent obstruction, and the renal insufficiency. The selection of procedure for the active removal of the ureteral stones, the overall stone-free rate, and the after the URS or the shockwave lithotripsy for the ureteral stones are comparable. However, the largest stones achieve earlier stone-free status with the URS. The large multi-center non-inferiority trial compared to the URS to the ESWL for the ureteral stones. The ESWL could not be considered non-inferior to the URS with only 12% of the patient needing further intervention after the URS in comparison to 26% in the shockwave lithotripsy. The complication rate and the morbidity of the URS has been significantly reduced. A systematic review compared with the shockwave lithotripsy, the URS was associated with a significantly greater stone-free rate for up to 4 weeks, but the difference was not significant at the 3 months in these included studies. The ureteroscopy was associated with the fewer retreatments and the need for the secondary procedures. This is the EU recommendation. So compared with the shockwave lithotripsy, the URS was associated with a significantly greater stone-free rate for up to 4 weeks, but the differences was not significant at 3 months in the included studies. The level 1A evidence. And the ureteroscopy was associated with the fewer retreatments and the need for a secondary procedure, but with the high need for an adjunctive procedure, greater complication rates and longer hospital stays. In the case of severe obesity, the URS is more promising therapeutic option than the shockwave lithotripsy. EU recommend that inform the patient that the ureteroscopy has a better chance of achieving the stone-free status with a single procedure. They inform the patient that the URS has a higher complication rates compared to the shockwave lithotripsy. The use of URS as a first-line therapy for the ureteral stones in case of severe obesity. This is the flow chart that the proximal ureteric stones with the more than 1 centimeter. The first option is a URS, can go with the anti or retrogrades. And the second option we can consider that shockwave lithotripsy. The less than 1 centimeter, shockwave lithotripsy or the URS. For the distal ureteric stones, For the more than 1 centimeter source, is the first choice is the URS. Then second choice you can go with the subcoil lithotripsy. If it is less than 1 centimeter in size, you can consider the subcoil lithotripsy or the URS. So the treatment decision depends on the location. If it is the proximal and the mid-ureters, almost same as the proximal and the mid-ureter management. So primary option include the subcoil lithotripsy and the URS, or the PCNL and the anticline nephroscopy also an option. The defined outcomes in the proximal and the mid-ureteral stones of all sizes in patients who underwent the subcoil lithotripsy with the overall 82% and the 73% treatment success rates respectively. The proximal ureter stones that are 1 centimeter or smaller, the subcoil lithotripsy success rises among these pooled series to 90% and 84% for the mid-ureteral stones. For the stones larger than 1 centimeter, rates of complete stone clearance drop in both groups to 68 for the proximal and the 76% for the mid-ureter stones. The outcome success for the URS for this location and the size, demonstrating an overall success of 81% for the proximal and the 86% for the mid-ureteric stones. The cost efficiency of the management of the proximal ureteral stones has been shown to be superior for the URS when compared to the subcoil lithotripsy. For the very large proximal ureteral calculi, not amenable to the either subcoil lithotripsy or the URS, including the large dense stone severe inflammatory response at the site of the stone impact channel. So we can the percutaneous and the anticlinate approach may be ideal. The laparoscopic or robotic ureteral lithotomy have been described for the proximal and the mid-ureteral calculi with the success rates of stone clearance in selected cases about 93 to 100%. For the distal ureteral stones, as discussed earlier, the distal stones are most likely passed with observation of the medical experts. Correct. The subcoil lithotripsy and the URS remains the mainstays of treatment for the distal ureteric stones. So the subcoil lithotripsy for the distal ureteric stones, the overall success rate was 74%. For the stones 1 centimeter or smaller, and overall success rate is about 86%. And whereas the stones larger than 1 centimeter, the success rate is about 74%. The URS for the distal ureteric calculi was shown to the success rate was about 94% with the stones 1 centimeter or less. It is about the 97%, and more than 1 centimeter is about 93%. The treatment by the stone comparison, if the known able to predict the radiologically, can be useful in selecting the most appropriate. The calcium phosphate stones, calcium oxalate stone, oxalate monohydrate, and the cystine stones are more resistant to the subcoil lithotripsy. So can be expected to have a better rates at all size and the location with the URS. The assessment of the ureteral stone density based on the ounce-filled units on the CT scan offer the valuable predictive ability to as the stone-free rate using the subcoil lithotripsy. So one of the complications of the subcoil lithotripsy is a strain stage. There is an accumulation of the stone fragments of the stone gravel in the ureter and may interfere with the passage of urine. It occurs about the 4 to 7% case of the subcoil lithotripsy. When the strain stage is asymptomatic, we can manage with the conservative treatment. With the medical expulsion therapy, increase the stone expulsion and reduce the need for the endoscopic intervention. And if the patient is symptomatic, we can consider the ureteroscopy and the subcoil lithotripsy are effective in treatment option. When considering the anatomical factors, if the patient with the megaureter, so the congenital megaureter is most often seen in the children and usually represented as an abnormality of the distal ureter or the VGJ, in which there is either a peristaltic segment or the incompetent VGJ. The previously reimplanted ureter may be difficult to access in a retrograde fashion, limiting the ability to place the stents or approach the stones via the URS. In a non-obstructed megaureter, the medical expulsion therapy, subcoil lithotripsy, and the URS are the viable initial strategies. In the obstructed megaureter, the strategies to manage the stones and the underlying pathology have included the retropulsion of the stones to the kidney and the treatment of stones via the PCNL and repositioning the patient to perform the ureteroneocystostomy, and the ureterolithotomy and with the ureteroneocystostomy with open robotic system. The ureteroscopy with the endoureterotomy in a short segment cases less than 3 cm, which could make the concomitant ureteroscopic treatment of the stone possible. The patient with the duplicated collecting system, so the incidence of approximately about the less than 1%, and the complete duplication, so the separate ureters enter the bladder with the more medial and the inferior orifice draining the upper pole, whereas the more lateral and superior orifice drains the lower. So the incomplete duplication, there is only one ureteral orifice on that side within the bladder, with the variable level of bifurcation of the separate ureters, which lead to the upper and the lower moieties. The limited reports describing the URS management of the stones in partially or the completely duplicated system. The phylography should be found before the intervention. The ureteral stricture of the stenosis. So the untreated stricture of the stenosis precludes the pregnancy passage and hence creates the expectation of the software lithotripsy failure. If possible, URS is preferred management strategy. The endoureterotomy should be undertaken as a first stage with the placement of stent. Allow the healing and subsequent URS to manage the stones at the second stage. Or we can consider the open or laparoscopic or robotic assisted treatment for the stricture and the stone in the same session. So when considering the clinical factors affecting the ureteral stone management, the urinary tract infection, the previous speaker that Divika has spoken about this, and the morbid obesity, and URS may be preferable treatment modality for the obese patient without exceeding the complex or the largest stone burdens. The patient with the spinal deformity, the software lithotripsy is often unsuccessful with the high retreatment and the actual procedure rates because it can be difficult or impossible to properly position patient for the lithotripsy table. And the PCNL and the URS are good alternatives to the software lithotripsy, and both have used with a good success, although special consideration are necessary. The patient with the uncorrected coagulopathy, software lithotripsy, and the PCNL are contraindication, then we can consider the URS as a treatment option. The patient with the urinary dilation, in general, the software lithotripsy, PCNL, and the integrated URS, retrograde URS, and combination can be explored. So without urinary obstruction, single session of software lithotripsy can achieve the success rate is about 60 to 65%. And the retrograde URS is usually confined to the flexible instruments, and the redundant ileal contive and the large capacity urinary reservoirs with some form of non-reflection ureteral anastomosis often require the flexible instrument to locate the ureteral orifices. The success rate is about 75%. The percutaneous access can allow the antegrade URS to achieve the access to the ureter when retrograde techniques fail. So my previous speakers talk about it ES-double, so I can skip these slides. So ureteroscopy, we can do the antegrade or the retrograde, and the percutaneous antegrade removal of the ureteral stone is a consideration in a selected cases. If large more than 1.5 centimeter, impacted proximal ureteral calculi and dilated renal collecting system, when the ureter is not amenable to the retrograde manipulation. We can do with the dust and go strategy. So the stones can be extracted by the endoscopic facets of the basket following the URS treatment. So the most effective lithotripsy system in the holmium laser, which is the currently optimum standard for the URS and the flexible nephroscopy. The pneumatic and the ultrasound system can be used with the high disintegration efficacy in the rigid URS. However, the stone migration into the kidney is a common problem. The medical expulsion therapy following the laser lithotripsy increases the stone free rate and reduce the colic episodes. The stent should be inserted in patients who have increased risk of complications such as the ureteral trauma, residual fragments, bleeding, perforation, the pregnancy, and in all doubtful cases to avoid the stressful emergencies. These are the EUA recommendation regarding the URS laser tripsy, and the complication of the ureteroscopy, the overall complication rate after the URS is about 9 to 25%, and the evidence suggesting that risk of postoperative urosepsis is up to 5%, and the ureteral levels is less than 1%, and the stricture is about 3 to 6%, and the perforation rate is about 0 to 4%. Thanks.
Yeah, thank you very much. You can unshare the screen.
Okay.
Well, then we'll move to the experts, Dr. Ranga and Dr. Niroshan. So anything to add?
More or less straightforward, doesn't it? Anything else?
I think you covered almost all the things. Only thing is what will be your guidelines of treating stones in a solitary kidney, precious kidney, transplanted kidney? Thing different to what you have said?
So we have in the solitary kidney or the transplanted kidney that we can wait for the conservative management. So that we need to do intervention to prevent that kidney function. So immediate imaging to look for any evidence of obstruction. So we can consider that intervention before rather than that conservative or medical expulsion therapies.
Yeah, your guidelines won't change much, but the thing is you need to have a high index of suspicion when you should intervene, and the detection of obstruction is much far more easier because the patient becomes suddenly anuric, or the creatinine keeps on rising suddenly within a span of 8 to 12 hours. So if that's so, you just immediately intervene and they recover very fast. I think that's all from my end.
Thanks.
Could I ask a few questions about the medical, the metabolic evaluation? Okay. If somebody comes to you with a ureteric stone, what's your policy on doing metabolic evaluation on him? Give us a small brief overview for the benefit of the trainees.
Sorry, sir, but I couldn't get your question.
So if somebody comes to you with a ureteric stone, yeah, what is your policy on doing a metabolic evaluation? Would you sort of
if the patient with
everybody
all the
or-
patient with the first episodes of ureteric stone, we need to consider the metabolic metabolic screening. The patient who are on the treatment for the metabolic screening with during the treatment, if the patient get again stone formation, we need to consider that. And the patient who are with the long standing, that who has been treated for the
could I have a small clarification? So all the patients with first stone, do they have to undergo metabolic evaluation? Is it? What does the guideline says?
things you recommend that all patient with the first episodes, but patient who are with the male, but being the clinical practice in the here, so we are using the patient with the children's and the recurrent episodes only. We are doing the metabolic screenings.
So I think you need to be clear on that. So the guideline specifically says, if somebody comes with a ureteric stone or any urolithiasis patient, if there is a first stone, right? If in the first instances, you need to have a stone analysis. Okay, that is the first thing that you need to do if somebody comes to you with a stone. Okay. And everybody with the first episode, they need to have a stone analysis. And then the rest, whether you're going to do a metabolic evaluation or not, depends on whether your patient belongs to a low risk category or high risk category. Okay. So high risk category patients are the ones that you just mentioned. And patient who develop stones rapidly after the complete treatment, bilateral stones, family history, patients with metabolic disorders, right? Any non-calcium stones, and they are the patients who are they are the patients who are high risk, right? So if everybody else is low risk, isn't it? So then it's easy. So the low risk patients should have basic panel of investigations, and that includes what? Serum calcium, phosphates, and uric acid, and electrolytes. Also, the guideline recommends UFR as well as urinary pH. So those are the basic panel. Everybody should have the basic panel in the first instance, plus the stone analysis. Okay. And everybody else who are high risk should have the advanced panel, and advanced panel involves 24-hour urine analysis, plus we always forget that the dietary diary, right? So the guideline clearly recommends dietary diary as well as the 24-hour urine analysis. So please be clear on the guideline on the metabolic evaluation. That is how you need to answer if somebody asks you about the metabolic evaluation on the benefit of the trainees. I just wanted to mention that is clear. The second thing I wanted to highlight for the benefit of the exam, as Muni said earlier, that we need to, now this is where you can show your knowledge on the papers, right? Show your knowledge on the papers, because now this the medical expulsion therapy has been sort of going in waves during the last 5 or 6 years, right? Because there were so many studies came into the play, so many controversial sort of practice challenging kind of things came to the guidelines, especially in the metabolic evaluation of medical expulsion therapy. So you need to mention about the two studies, right? So one thing is the suspend trial. So you need to mention, and the other one is the mimic trial, right? I think Suranga has also kindly mentioned that about the mimic calculator, right? So he has point out. So the current, the available data, the latest data. So if somebody asks you, given you a stone and sort of give you the characteristics of the stone, like let's say 7 millimeter upper uric stone, how are you going to guide the patient? So you have the mimic calculator, you can tell them the spontaneous expulsion rates, and based on that, you can sort of offer them whether you're going to go for a spontaneous expulsion or whether you're going to go for an intervention. I think, Moni, is there anything to add, or Taha, Dr. Ranga?
No, we have covered all the areas, I think.
Yeah. So shall we wind up the today's session?
Yes, Nishant, I think we can. No?
And yeah, so on behalf of the academic committee, I would like to be very grateful for both of our expert, Dr. Ranga Vikramarachi, as well as Dr. Niroshan Senuratne. Thank you so much for being here, spending your valuable time on behalf of the trainees. And I would like to thank all the trainees who presented, as well as my co-moderator, Dr. Munipriya Villararji. And so you need to read quite a lot and read all these papers which we mentioned and establish these things into your long-term knowledge. So thank you very much, and have a pleasant evening. Thank you so much.
Yeah, thanks, Nishant. Thank you, and Muni, thanks for organizing this.